Okay, so I am really excited to introduce all of you to my dear friend and colleague, Erin Cassidy-Eagle. I'll give you her formal introduction and then a little bit of personal introduction. So she's a clinical professor in the Department of Psychiatry and Behavioral Sciences at Stanford, where she is an attending psychologist as well as co-chief of the Geriatric Psychiatry Outpatient Clinic. She has more than 25 years working with older adults and is board certified in behavioral sleep medicine. She also currently serves as the president of the board of behavioral sleep medicine. She has a special interest in and expertise in how sleep, cognition, and mental health interact with one another. I have known Dr. Cassidy-Eagle since 2001. I think that's correct, Erin. When we met at the Summer Research Institute for Geriatric Mental Health. And so it has just been a delightful journey being friends and colleagues. And we were fortunate to start working together in 2015. We both came to Stanford at the same time and started, or she came back to Stanford and I came there. And we worked very closely together in the geriatric psychiatry section and clinic and a lot of different educational and clinical and research activities. And we co-edited one book together, which was a wonderful journey together. And we are in the process of doing another one that actually really is Erin's brainchild on psychotherapy in older adults. She is one of the finest psychotherapists and clinicians that I have had the honor to get to work with. So she was out here last week in person to be one of the speakers at the investiture, which was then canceled. And we had to, we got her out on the last flight, basically, because she had a hard stop and had to get back to California and was able to get back to give a talk at one of the residential care communities out there. She gives a lot of talks in the community to older adults, to clinicians, and is an expert, as I said, in sleep in older adults, as well as many other topics in geriatric mental health. So Erin, welcome, and we're very excited to have you.
Thank you. Thank you for that really sweet introduction. And I'm sorry I didn't get to do this in person. I was there, but so was the ice. And so, but I'm excited to still get to talk to you guys about something I'm really passionate about. In fact, I like to start with a little confession, which is I have a grandmother who lived to 104, and she was absolutely certain that water, just drinking more water, could cure anything from skin problems to a bad attitude. All you had to do was drink more water. And as much as I used to laugh about that, one, I do drink more water, but two, I have to admit, I kind of feel that way about sleep. So I'm here to try to convince you all to feel the same way about sleep, but I like to at least warn people that's the place I come from. So today, I really work solely with older adults. And so I'm just going to talk about insomnia more broadly, how it affects and interacts with your mental health and physical health, changes we see with age, ways that we typically assess it, the most effective treatment options. And I'll kind of work through a case to kind of give you an example of a typical patient that I see and some of the considerations that we take into account. So as I think probably, and as I'm going here, if you have questions, just flag me down and I'm I'll try to pause enough. So happy to just talk more about something if questions come up. In terms of diagnostic criteria, I think we're all pretty familiar, but I think the key is, at least 3 nights per week for at least 3 months, despite the adequate opportunity for sleep. Now, with older adults, that's typically not an issue, but in younger adults, if someone's working the night shift or has a different schedule as a caregiver, sometimes they don't even have the opportunity to get enough sleep. So that does matter. And I think, it's helpful to think about what is typical. So what is not disordered, 1 to 2 nights of bad sleep a week, is common. And so it's not something to be concerned about. We do get a lot of folks that come in, as you guys probably see, that will say, hey, I've had terrible sleep since I was 12. I will say those folks are always harder to treat, but I usually feel like there's something we can do to improve their situation. In terms of insomnia and thinking about where does it come from, certainly we want to rule out other primary causes of sleep disorders, sleep apnea, restless leg, other rarer things like narcolepsy. But in terms of insomnia, typically there are folks that we call premorbid conditions. So whether it be gender, so female gender, having other psychiatric illnesses, other being on different medications, that puts people at risk, more at risk of developing a sleep problem. And then we often see some sort of precipitating event. Now, this could be a good event or a bad event. So you could win the lottery, you could have a child, you could lose somebody, you could get diagnosed with a tough illness. So it could be good or bad, but typically something that, causes a sleep disruption and, for several days. And then what people that get insomnia, what we see them start to do is they start trying to sort of fix their sleep. So one of the ones I hear the most is, oh gosh, people stay in bed longer. They say, oh, I get my best sleep in the morning. So if I have trouble sleeping at night, I just stay in bed longer and I make up for any lost sleep. Or I drink some warm milk with vanilla. They start kind of like scaffolding their sleep with these different tools that, although they help in the short term, they really actually exacerbate, sort of, solidify the sleep problems. And so they keep having to do those things, and yet their sleep problems are still there. I think, older adults in particular, so more than 50% at any time will be complaining about sleep. Just like the rest of the population, probably 10% meet actual criteria for insomnia. But I've found that it is one of those symptoms that, for example, even if you have a successful treatment for depression or anxiety, it's one of those residual symptoms that often remains. So it can be a little tougher to treat. And how I think about it, you can see that, for example, I think the key thing here is it's bidirectional. So having sleep problems put you at risk of having other psychiatric problems, and having psychiatric problems often include some component of sleep that remains. An example in veterans, there's been several studies that have shown that, pre-deployment, that if someone has insomnia or sleep problems, they're actually almost 2.5 times more likely to develop PTSD. And likewise, if they're diagnosed with insomnia at the same time as major depression, they're also more likely, more at risk for suicide. Physically, even separating out other variables, sleep really actually increases all-cause mortality, increases obesity. It really messes with leptin and ghrelin. And so whether it's, satiation or hunger, it throws both of those off. It puts you in greater risk of diabetes. And one thing I found especially interesting in the last couple of years is immune responses. So we know that if you have disrupted sleep the week before you get the flu shot, that when you get that flu shot, you develop only 50% of the antibodies that you would develop if you had solid sleep the week before. So there's some interaction with the uptake of those vaccines, depending on your sleep just before you get it. And I think, especially in the era, and I so apologize for these animals. That's the door. So sorry. The joys of working at home with too many pets. But, especially in the era of vaccines and different treatments, it'll be interesting to see what research shows in terms of ways that we can actually improve someone's immunity through something as simple as. Now, let's see, when we're looking at increasing age, we know certainly complaints increase, the use of hypnotics increase, and architecturally, we see that sleep is slightly shorter, but by shorter, it's not too bad. So if you're 40 and you sleep 7.5 hours, when you're 70, you're probably still going to get maybe 7 hours. So it's 30 to 40 minutes. But I think the key change that people complain about and that we see on polysomnography and actigraphy is that people wake up more. Their sleep is lighter. So these things are obviously related. Deep sleep is something that decreases over your lifespan by about 80 to 90%. So maybe you had 90 minutes of it when you were 20. You're only getting maybe 15 to 20 minutes each night when you're 70. And this is important for several reasons. In your deep sleep, that's where we sort of, I like to think of the brain as like a filing cabinet. It's where we sort out memories, associate things together, really do things that improve our memory retention. If you studied for an exam for 8 hours and you took that exam versus you studied for 8 hours and then just slept for 8 hours, then took the exam, we know people score 30% higher if they just had that sleep in between. So they didn't study anymore. So there's this process that does happen during sleep that really kind of organizes things that you experience and learn during the day. We also know as you get older, so the area of your brain that controls, that mostly controls deep sleep is sort of the mid-frontal lobe. And that when we look, for example, with sort of degenerative processes, that's where we see amyloid deposition, which you might associate with Alzheimer's disease and some other things. And we know that in deep sleep, there's cerebrospinal fluid kind of works as like a wash. It flushes out some metabolic debris in the brain, including amyloid. And so it becomes this vicious cycle that we have some amyloid, so that also impairs our ability to get deep sleep. So then we have some more amyloid deposited because not as much flushing happens. And it sort of keeps going like that in a way that I think several people smarter than me are really working on. I know it is Matthew Watson at Berkeley and some other institutions are really trying to figure out, are there artificial things we could do when older adults are sleeping that will increase the amount of deep sleep they get in hopes that not only do we sort of improve cognitive functioning, but maybe we actually can impact some of these disease processes. It's early stages, but different things like brain stimulation during wakeful hours, cognitive training, there's lots of different things people are sort of experimenting with right now to see if we can increase the amount of deep sleep folks get as they get older. Okay, shifting to assessment, and I'll pause there. Are there any questions before I move on? All right, just wave at me if things come through. So I always like to include this just because it makes me laugh. So this is my husband and my twin girls. And I'd often find him like this when it was his shift. And then he'd be in really big trouble because I'd be afraid he's going to drop him. But, we all go through those periods of life where we're incredibly sleep deprived. But, I think as we get older, looking for signs like snoring, even if when you're falling asleep, when people say to you, gosh, I fall asleep in 30 seconds, that's actually not good. When an older adult says that to me, I immediately think, oh, sleep apnea. I want to get them assessed. I think if they're complaining about being sleepy while they're driving or falling asleep, I call them, there's intentional naps and unintentional naps. So if people are falling asleep when they're not trying to, I think it's always a great idea to get an overnight polysomnography, get a full sleep study. It isn't good at detecting insomnia, but it's good at detecting just about everything else. And I like to rule out everything else, or at least know what other things are playing a role. So that might guide treatment. Okay, Harold. So Harold is a typical patient that we might see in the clinic. I often get folks referred by their PCP. Harold, for example, was living alone, retired a year ago, came to me with the question that he'd been having trouble sleeping and had been started on Ambien, but even with some changes in dosage, felt like he was still, it just wasn't, it worked at first and then it kind of stopped working. And he did have some health problems. He was evaluated and had a pacemaker placed, but he just wasn't feeling as sharp, and he was just feeling like there's some things I could do maybe on my own that can improve my sleep and maybe make me feel better. So I'll talk about some methods of assessment, and we can talk about what we did with Harold. There's direct observation. Now, that's terrific if someone has a spouse, but really it's only as good as the frequency of the recording. So I certainly don't expect someone to stay up all night and watch someone to see how much they're sleeping. It's similar to sleep diaries. I call them sleep thermometers. Those are terrific to do and often can be an intervention in and of themselves to have people record. I'll show you some examples of those. But I rely initially on a really detailed sleep interview. I like to know kind of, hey, walk me through a typical day. When do you get up in the morning? How active are you? Do you eat at regular times? Do you get exercise at regular times? And what time do you get into bed? Do you read? Do you stare at a screen? If you do wake up in the middle of the night, are you looking at your phone? We know that even some bright light like that in the middle of the night can shift our circadian rhythm a little bit. So it's just good to try to get that information. In terms of daytime functioning, I do want to hear about, we don't have as many smokers, but still some people smoke. How much caffeine do they have, including chocolate? There's lots of sources of caffeine that we often forget about. And I think with older adults, and I know Laura and I have seen a lot of that in mutual patients, we see a big increase in alcohol use, and especially in women. So it's something that I now routinely ask about. One of our colleagues calls it inadvertent alcoholism, that someone's maybe living alone, they're bored, they're starting to drink a little more than they have been in the past. And they don't even identify them as drinking a lot, but it slowly over time becomes to a point where, it certainly can disrupt their sleep and their health. There's sort of the myth of the nightcap. And what we know with alcohol is that, let's say you have alcohol just before bed, that when you metabolize it, it activates your brain. And so you have people waking up in the middle of the night. Certainly, there's a range of medical conditions. It's nice to do sort of a complete review to make sure that there's no other factors that could be affecting someone's sleep. Sleep diary. So let me show you. So I like this version, the sort of numerical version. I have something like this. And if anyone wants a copy of it, I created it from a sort of consensus sleep diary that the sleep research community created. I'm happy to email you guys a version that is in Word that you can sort of modify and use for your purposes. But I think if you can't really tell, but if someone's going to only fill out 2 lines, I want to know when they got into bed and when they got out of bed. But I'd love all the other information as well, to just try to get an idea of what's a typical sleep pattern, how much effort are they lying in bed for hours each night? Most people are able to fill this out. Some people prefer an assessment kind of like this, where you just draw lines when you're asleep. This is nice, especially if you suspect a circadian rhythm disorder. So we really see those in adolescents, but older adults, we call it advanced sleep phase disorder, where they're falling asleep. They do have an earlier release of melatonin, just physically. So we do see people, for the most part, we still get night owls, but for the most part, you see people kind of falling, getting sleepy a little earlier and waking earlier. And so this is a really helpful way to see if that's what's going on. And then you can see the naps there. So I often look at those and say, hey, on days where there's naps, is there a big delay in sleep latency, i.e., do they fall asleep a lot later than the other days? So you can just kind of see patterns, look at weekday versus weekend, but, what we really want this to look as consistent as possible. And we know that they're getting solid sleep. One of the things I always say to them, hey, is I'd rather you get 6 hours of solid sleep than 8 hours broken up across 11, just because you're going to feel very differently. Some of the common, go ahead.
Excuse me, I'm seeing an error message on the screen. Does anyone else see that? An idle timeless?
Yeah,
thank
there.
you. Thank you.
Yeah, sorry, I've never seen that before.
Oh, it just
Thank
popped
you.
up.
Okay, good. Thank you for telling me. So these are a lot of the abbreviations you see when people report, how long does it take to fall asleep? How often do people wake up? For how long? Total sleep time, sleep efficiency, that's basically out of the total amount of time you're in bed, how much, what percentage are you actually asleep? So we would love people to be asleep 90% of the time that they're in bed, but anything below 85, we start to say, hey, there's some room for improvement here, because it's the Pavlov's dogs example here. You don't want people lying in bed, awake, frustrated, and associating being in bed with being frustrated. You're going to see that then becomes a real repeated pattern. Okay, so Harold. So we looked at Harold's sleep, and his sleep problems have been going on for about 6 months. He was started on Ambien at 5 milligrams. It helped for a couple months. Then it sort of waned. They increased it to 10. It didn't seem to make a difference. What we did notice, just even on his sleep diary, was that he reported getting in bed usually at 11. He did wake up a lot during the night. And then he reported having to force himself out of bed at 10 a.m. So really, when you think about it, he's in bed 11 hours. So if the average person sleeps between 6 and 9 hours, and older adults probably on the lower end of that, let's say 7 hours, then already he's going to spend 4 hours awake. So immediately you can kind of see some areas that we could intervene behaviorally. He did also report no intentional napping, doesn't take naps during the day, but he does talk about falling asleep or watching TV at night, which I think a lot of us can relate to, but kind of give us a little bit better picture of what's going on with them. Just to kind of review in terms of sleep measures and assessments that I like the most, there's certainly the PSKI, the Pittsburgh Sleep Quality Index. That's really good to measure sort of general sleep disturbances. It does account for a bed partner's input as well. I will say that to do that quickly in clinic, I find it a little bit more clunky to score really quickly. So I found I really like it in research, but if I'm doing a quick clinic assessment, the two I use the most are the Epworth Sleepiness Scale to just get an idea of all the activities in which someone's feeling sleepiness. And the Insomnia Severity Index, that's sort of the main one I use. It's only 7 items, and it really lines up with the DSM criteria, so it helps you diagnostically too. And a lot of studies do use it to see if the problems have remitted, so it's helpful in that way. Actigraphy, I'd say very quickly here, it's getting replaced with all these wearables we have. But for research, it still is, a little bit superior. I think it's hard with the Fitbits and Apple Watches because if you're doing research, you can't access someone's data. They have to share it with you, or you have to purchase a whole bunch of these. They're a little bit harder to use in that capacity. And these are really great for older adults, especially if they have memory impairment. They don't have to do anything with it. They just wear it. The battery lasts a long time. It measures light exposure. And there's no buttons, nothing they need to push. Here's an example of what kind of data you get when you use an actigraph. So I often use it in concert with a sleep diary. So the pink bar there is, I compare it. So I plug in, when did they say they got in bed? When did they say they got out of bed? So that's that window. The blue is movement. Basically it's a accelerometer that detects activity. So you can see when people maybe got up to go to the bathroom in the middle of the night. And if there's yellow, the yellow is how much light they're exposed to. Now, I'll be honest, this is an assessment of me. So I was exposed to a lot of light, and with older adults, we often see a lot less. But I think, that's sometimes some of the main issues is when can we add in exposure to light? How can we regulate when they get in bed and out of bed? And the bottom right there, it'll kind of calculate for you over several days, what's the total amount of time people are spending asleep, how much time after they initially fall asleep, the WASO, the wake after sleep onset. So after they initially fall asleep, how much total time are they spending awake in bed? How many times do they wake up? Now, as you go through about 5 sleep cycles a night. Between each one of those, everyone has a brief awakening. A lot of people will roll over. They won't even be conscious of it. If someone else maybe has to go to the bathroom, then that's the time often that your body will kind of wake you up more. And I think some awakenings aren't real concerning as long as you fall right back asleep. But this is a great way across, a week's worth of time to compare and look at someone's sleep. I think COVID even lit a fire under this. The home sleep apnea devices for screening have gotten even better. They were good several years ago, and now they're actually used a lot more commonly. They're really simple. They have a respiration band around your waist, a pulse oximeter on your finger, and a nasal cannula. And I've had several people wear these overnight for a study, and then go in and get an overnight test, and the results as far as apnea are really similar. So they're very good. And I think if you're doing any research in insomnia, it's a nice way to sort of screen for that and rule out folks that maybe have a severe sleep apnea that will be tougher to treat, or just to, do it clinically. A lot of sleep centers now are using these pretty regularly. This is an old picture, obviously, but I think it is also good to remember that if someone's main problem is insomnia, we're not going to be able to detect that in an overnight study or even the improvement of it. But it's still useful for ruling out other problems. Okay, treatment. I'm going to pause, wave at me if there's any questions. Otherwise, I will just keep plowing through here. Okay. In terms of evidence-based treatments, it really comes down to two, hypnotics, and then what they call multi-component cognitive behavioral therapy for insomnia. Lovingly, we call it CBT-I. So those are really the two. And I think when we compare the two, so when we do studies on them, they both are really equally effective. Here's the difference, is that, you look at it in the first 6 months, they're pretty neck and neck. But when the studies stop or people are taken off hypnotics, you often see the sleep problems rebound. They typically come right back. Whereas with CBT-I, when we teach people kind of different ways for them, personalized, to manage their sleep, when they are out of the study or have problems in the future, they're able to do things that kind of realign their sleep. So longer lasting effects, certainly with older adults, anytime we can give them off a medication is also a great thing. I think when you think about the behavioral treatments, which I'll kind of just give you a quick review of, it's helpful to understand how the sleep-wake cycle works, sort of the underpinnings of these recommendations. And I try to explain these also to patients so they really understand where they're coming from. I think patients are used to seeing things in magazines and different things that they feel like, oh, I've tried everything, nothing works. But what we usually find is that they're not super fun always to try, and that maybe people tried, getting up at the same time every day for 3 days and felt pretty miserable doing that. So, sometimes they just don't try long enough. So I really try to talk about, there's two biological processes under sleep, and they never break. Some people feel like, oh, my sleep is so screwed up, there's no way you can fix it. It's broken. The good news is that's never true. Can't break it. So one is your circadian system. And this really affects everything from your core body temperature to how alert you feel. Most of our body systems are on some sort of rhythm. You see that when you first wake up, so the light affects it. It, can suppress melatonin, which will make you sleepy. So light and dark, other things help keep your circadian rhythm regulated. And so that's why we talk about having those kind of anchors, because, if you're exposed to light in the morning, you minimize bright light exposure in the evening. That keeps melatonin in sync, and that really does help you sleep better if things kind of happen on a regular basis. So when you first wake up, those arrows are alerting signals that are waking you up. You'll notice it's a very small difference. And if I had a laser pointer, I'd point it to you. But at about 3-4 o'clock in the afternoon, it doesn't just go straight up. There's a tiny dip. And a lot of times people associate that with post-lunch. Oh, it's after lunch, so I'm a little sleepy. It's actually got nothing to do with food. It's really, in most of our system, in the later afternoon hours, probably I'm getting you guys right at that time right now, which is your core body temperature dips a little bit. And it's just for about 45 minutes, but it's enough to make people sleepy. So if you find, and most of us do, there's some point in the afternoon where maybe reach for the caffeine, or we feel like, oh gosh, I want the day to be over. It's typically in that window. And if you are someone who does lie down to rest, this is the perfect time to do it. But it also won't last that long. So it's just kind of good to know that's just part of the natural pattern. And then you see sometimes there's almost like a second wind in the evening, just before we go to bed. And then the signals start to drop off and allow us to fall asleep. The other system is our homeostatic regulation of sleep, or our sleep drive or sleep load. You might hear people talking about it. So that's on the top part of the graph. And it's, if you woke up in the morning and you just slept 8 hours, and I said to you, hey, can you go back to sleep and sleep another 8 hours? Most people would say, I can't do that. And that's because you've kind of met that need. So it's just like if you have a meal, you're full. You're not going to be able to eat another meal right away. But as you get further away in time from when you woke up, your sleep drive slowly builds. It is related to a chemical in the brain called adenosine. And that's actually the same chemical that caffeine works on. So I always like to tell people, if you're a coffee lover, don't have it right when you wake up before you get out of bed, because there's really nothing for the caffeine to work on. So if you enjoy it, have at it. But really, if you wait a couple hours and some of that buildup of your sleep load has started, then you'll notice an impact from the caffeine, giving you a little bit more energy. The other thing is, if you go into maybe 5 o'clock or 6 o'clock and maybe someone falls asleep, an older adult falls asleep in front of the TV, what you'll notice is those arrows might be cut in half. So even that little micro sleep in front of the TV, you hear people say, gosh, I was falling asleep in front of the TV and I went to bed and then I was wide awake and I was just so sleepy. And it's because of this, you had this little micro sleep and it depleted your adenosine and your sleep drive. And so unfortunately, the only way really to manage it is to stay awake and let it build back up. So that's the sort of danger of having those unintentional naps or sleep in the evening. It's better to have it earlier in the day. I say I'm pro nap. If you want to have a nap, 7 to 9 hours after you wake up is an ideal time to do it. And lastly, I put the lion on here because in addition to these biological processes, we certainly have our brain and any sort of arousal, excitement, happy, sad, anxiety, anything emotional certainly affects our sleep. And so that's sort of the third component that we think about when we do behavioral treatment. So we want to do things that improve your sleep drive, sort of stabilize your circadian placement, and decrease your arousal. And those are sort of the three main things I think about in terms of promoting good sleep. When people come in, kind of how I explain it is, when I talk about the model, I say, hey, you have physical things going on, illness, pain, that may make you stay in bed more. That may lead to feelings of frustration or anxiety because you might be missing certain things. That may lead to thoughts of, oh gosh, if I don't get good sleep, I'm not going to be able to perform tomorrow. I better cancel everything. And it kind of becomes a vicious cycle. And in terms of what I can do to help, I can't reach in and cure your physical problems. I also can't reach in and instantly change your emotional health. That's a longer process. But what I can do in a quicker way is we can talk about how to manage worried thoughts, but really behaviors is the bigger target in sleep. So how do we change what you're doing that could improve your sleep? Okay. For CBT-I, so the main components that sort of come out of that is stimulus control. And I talked about that a little bit. It's the Pavlov's dogs. We want to keep the bed just for sleep and sex. Sleep restriction, which and those two are the most helpful, is really minimizing the amount of time you're in bed closer to the amount of time you're actually sleeping. Now, with older adults, I don't like to just say, okay, we're only going to be in bed for 6 hours. We can do that maybe with, 25-year-olds. With older adults, you have to take into consideration mobility issues, pain. There may be other things going on. I like to do, it does take longer, but it's sort of milder. We call it sleep compression, which is we just start having them decrease slowly on either end, the amount of time they're in bed. It's easier to get people to stay up later, usually than get up earlier. because you can't force yourself to fall asleep, but you can set an alarm in the morning. So the only one we really have control of is that morning time. So we usually use that as an anchor and then say how much sleep you usually get and move back from there to figure out the bedtime. Relaxation's often part of it, sleep hygiene, the sort of low-hanging fruit of just good, healthy sleep behaviors, and then cognitive restructuring for those folks that, really worry a lot, find themselves ruminating in the middle of the night. So there's different techniques we might use for those folks. Okay, back to Harold. We still want to help him out. So the recommendations we used for Harold was, get up at the same time every day. Try to keep this as a consistent schedule 7 days a week. Only be in bed for the amount of time you're sleeping. Stay up until you're sleepy, till you feel like you're going to fall asleep. And then in the middle of the night, get out of bed if you're not sleeping. When you wake up and you find that your brain starts doing math, how much time do I have left? And you start calculating, then we know we might be awake enough that it might be good to step out of bed, do something that isn't too stimulating. We don't want to give insomnia a purpose. So when people tell me, oh, I get up and I do the laundry and I clean the kitchen, we don't really want to be productive, because then that's something that will also become a habit. For Harold, we recommended avoiding daytime naps because he was just in bed so much at night. We really just wanted to shrink that. We reviewed sleep healthy behaviors. And then I often am fortunate enough to work with amazing psychiatrists. So I usually try to work with them on how do we deal with the Ambien or any other sleep medication that they're on. I will tell you the strategy we often find really helps. It takes a long time, but one way to approach it is to consider going to the lowest dose possible. So the lowest dose that they've found is effective, and having them take the same dose every night. With the idea being you want it to be time contingent and not insomnia contingent. So we want them to do the same thing every night. We don't want them saying, oh, I'll try to sleep, and then if I can't sleep after half an hour, I'll take some more, because then that sets up this association between drug taking behavior and insomnia that really ties it together, and we want to break that. So if we can just have them do the same thing every night, initially it increases the amount they take, but then after that seems to stabilize and we're teaching them some of these different behaviors, then you can pick one night each week where maybe they don't have a lot of expectations or schedules the next day, where we say, okay, now every Saturday night, you're not going to take anything, but you're going to keep the same approach the rest of the nights. And no matter how awake you are, we're just going to stick with that. And so it's an approach that takes a long time, but it's one way of trying to do that. And that was something we tried with Harold, and it took a long time, but we were eventually able to discontinue the medication. Just some final thoughts that I like to include about older adults that, sometimes with mobility issues, getting up, going to another room, if they're awake in the middle of the night isn't realistic. So maybe we have a chair set up with a blanket and, not too bright of a light so they can look through a magazine close to their bed. Maybe some people I've had have surgery where I just have them get up and get to the other side of the bed, and just on top of the comforter. So there's ways you can kind of adjust it. You want to make sure that they're not going to be at risk of falling. Like I said, sleep compression over sleep restriction. I do talk to folks about planned versus unplanned naps. And if they really enjoy them and seem to need them, to try to plan them and schedule them and limit the amount of time can be really useful. With a lot of folks, and with Harold, for example, the next thing we went to was behavioral activation, to increase activity. We see this in a lot of residential facilities where staff go home and there isn't much programming offered at night, and there's bright lights and all sorts of things that really don't set people up for good sleep. And so if you can think about, having things that people are interested in doing and engaged and stimulated by, whether they're in the community or in residential care, I think all that matters for everybody at any age. And then finally, things like incontinence and different physical changes that result in either being sleepier and or needing to use the restroom more. We do find that if people are sleeping better, even if they're in bed less, that sometimes those things don't wake them up as much. And so they can decrease the number of times they get up, or we can find other ways to manage it, like decreasing fluids before bed. So there's a lot of customization that happens, but there's adjustments you can make so that at least they can still benefit. With older adults, I often decrease the amount I cover. I simplify things. I give them lots of handouts. This is some things I found in research really made a difference. I also wanted to just put a plug in for groups. I see a lot of people individually, but I found older adults, really, loneliness is an epidemic. So anytime we can actually do something in groups, not only is it more cost effective, but I find that the connection they get with other people adds benefits that go far beyond sleep. So I always like to try to implement it that way if I have that option. And then I'd like to include, there are lots of free resources. Many of you probably know through the VA, there's lots of free apps. CBT-I Coach is the one from that focuses on sleep. It's a great app. It has lots of different components to it. Helps them change their sleep schedule. There's some relaxation in there. There are other things if arousal is an issue. There's lots of other apps online that can be useful. And then I always like to share websites. As much as maybe there isn't as much jet lag for older adults, I do like to always share jet lag routes. So there's some other ones that really, if you're traveling, you can plug in your flight schedule and where you're going, and it helps you figure out if you take melatonin, when to take it, but also how to adjust your sleep before you leave. That I find really useful for being at your best when you get there. And then finally, I just like to recommend a couple books. Of course, my favorite is the one I did with Laura Dunn, and it has a great chapter on sleep that we did in that. But there are some other books that I find patients really like. Here's just a little snapshot from the chapter from Laura and I's book. It kind of talks about some typical presentations we might see. I'm happy to have my slides shared if people are interested in that. And then lastly, especially it's for physicians as well as psychologists. You probably saw at the beginning, I have these weird abbreviations after my name, CBSM, DBSM. There is a board certification that across disciplines you can take to sort of solidify your expertise in behavioral sleep medicine. I'm actually on the board, so if people are interested in learning more about that, I'm happy to have you ask about it or reach out to me later on with any questions you might have, and I'm happy to talk more about it. But otherwise, that is it. So thank you for listening.
Okay, thank you so much. With that, we'll open it up for questions. And Dr. James let me know in the chat that Dr. Tripathi had a question. I don't want to put you on the spot, but you may have had a heads up I was going to come to you. So
I had a question about melatonin and sleep.
Yeah.
CL psychiatrist by trade, and we see it being used as a sedative quite often on the general medical floors or even in the outpatient setting, with the thought that it is going to induce sleep. So my understanding was that is not what it does.
Yeah.
I was hoping you could comment on the use of melatonin, both over the counter and prescription and Remelpion use in the outpatient setting and its role in the inpatient setting, especially in like the delirious geriatric population.
Yeah, I know I do work with melatonin a lot more than Remelpion, but yeah, I'm happy to talk about that. People often use it as a hypnotic, and it really is a very weak hypnotic. In fact, we know that, so the good news is taking melatonin doesn't mess up your natural melatonin, so it just adds to it. But a couple of things, yeah, it's much more beneficial as a circadian sort of bolster, and you want to not take it right when you want to go to sleep. You really want to take it, 60 minutes before, because it takes a little while to sort of impact your system and make you sleepy. I will say in a lot of studies, it's used as sort of the control condition, because for a lot of people, it just isn't enough, especially if they have genuine sleep problems. In the US and in Canada, we have a lot of over-the-counter options, whereas other parts of the world, they require prescription. The other thing to think about, a lot of people like it because it is fairly safe. I think it's always good to tell your doctor any medication you take, whether it's a supplement, whether it's FDA regulated or not. It is fairly safe to use, so it's sort of low-hanging fruit for a lot of folks. But there was a study, I think it was 2017, I actually was just reviewing again last week. They looked at 30 different brands of melatonin, and in over 70% of them, the actual amount of melatonin in the supplement was off by 10%. So the labeled amount on the bottle was not really reflective of how much was actually in the actual pills when they tested them. And even the same brand over time, different lots had varied amounts. Not only many times was it less, but there were some that had 485% more melatonin than the labeled amount. And I'd say that the biggest offenders were actually chewable tablets, which are more often used by kids. So I think using a brand that you trust or that you see as more reliable is really important because it's not regulated. And so, natural isn't always safe, I like to say. And so it's good to really look at it. They also found that in 25% of the tested tablets that there was detectable levels of serotonin, which is when melatonin degrades, it produces serotonin. And, that even if it wasn't at a therapeutic level, it was still enough that, it would be good for people to alert their doctors that was part of it. So hopefully over time, they will become a little bit better. But yeah, it's not really a strong hypnotic. But I do more often have patients come in and say, oh, I take it right when I go to bed and it totally helps. And part of me says, okay, if they feel like it helps, if it ain't broke, I'm not going to fix it. I know that, that maybe that's as much placebo as anything else. I'm just always surprised when inpatient-wise they use it that way. I see another person asking about like CBD. I will say that's the other thing that nowadays, that's another thing like alcohol. I ask everybody because more than half of the people that come in for an intake are taking some form. I can't tell you how many older adults, they buy a huge amount if they live in a residential facility and split it between like 5 of them. It's a popular choice for pain, sleep, and anxiety. In the clinic, and you guys probably do the same. We don't recommend it. We don't send people, certain sort of places. The hard part is we just don't have any research on it. So a lot of people do find it useful for sleep, but we don't know how it interacts with other medications, medical conditions, what it does long-term, depending on, the sort of content of what they're taking, whether it's some people like the more psychoactive. I definitely have folks all over the map on that one. And so it's sort of, but it's something good to at least know if that's what they're trying. But yeah, sorry, those were, I answered probably things you didn't ask too, but these are some of my thoughts.
That was great. And I think it might cover then, Dr. Geist, does that totally cover your question? I think that may, but I don't know if there were any other pieces you wanted to ask.
And I am a melatonin fan, it's over other things. Listen, I'd rather them take melatonin than 2 nightcaps. So yeah.
Great. We're open for other questions. Feel free to just unmute yourself if you have one, or can put it in the chat.
I just have a comment. Well, in addition to, I have 2 comments. So wonderful talk. Really, I learned stuff, Erin, even though I worked with you. Oh, yeah, wait, we do have another question about white noise. Actually, I was curious about that too. But one thing I was going to say, you talked about this in a couple different places, I think, about how, kind of very gradual changes that you're recommending for people so that I know this about you, you have a ton of patience with your patients. So, I think it's something, do you want to say a little bit more about that or just
yeah.
Okay.
Just, I think sleep changes are hard. Gosh, when I think of, and I've done a lot of time rotating through with just, 40-year-old adults and other ages with sleep, it's hard. Some of the recommendations, if I can get somebody to do it exactly as I recommend it for 2 weeks, I can promise they'll see a change. But it's, it's really hard, even if we think for ourselves, especially if, you work during the week, to say, hey, I'm still going to get up at the same time on the weekend and do meals at the same time. Some of the recommendations, the other one people struggle with is they're awake for 2 hours in the middle of the night, but when you talk to them about getting out of bed, when it's winter and cold, or they live alone, those are harder things. So I do probably hold people's hand a little bit more with that and just try to make it as comfortable as possible. And I will say that does make it take longer. You can kind of pull the Band-Aid off quick or slow. But if that at least moves them along, it affects so many other areas of their life. I still feel like it's worth it. Just grab on white noise. I do think white noise, especially if there's other sounds going on, can be really useful in the hospital environment as well as at home. There's absolutely nothing wrong. That's sort of one that's an easy thing to use. And the other thing is masks. Some people aren't comfortable with wearing like sleep masks, but if you have light that you can't control, I think masks can be useful. People often ask related to light, can I go fall asleep to my TV? I'd rather you fall asleep to your TV than your phone. Now if you have a, iPad and you can flip the light and the light dark, they have a dark, nighttime setting, then that's a little bit better. But if you think about it, it's how close the light is to your eyes. The closer it is, the greater impact it's going to have in your sleep. So TV is sort of preferred. And sometimes people find it comfortable to sort of familiar sounds to fall asleep. I will say that even just that little light from the TV will keep you in a lighter stage of sleep. So there's pros and cons to it. But if it's something that you really have become accustomed to, maybe see if you can set up a timer to turn your TV off. There's just some little things like that. Just reading the chat here. Yeah, melatonin for jet lag. I think Ambien, melatonin, all those things really were designed for like short-term, whether it be you're going through a tough time or there's things that are disrupting your sleep and jet lag. They were really designed for those kinds of things. And if you look at that jet lag rooster, they obviously feel really good about melatonin and even tell you how to dose it and when to take it. The other thing I always like to say is with melatonin in general, more isn't more. So 3 to 5 milligrams is a standard dose. You don't really need 20 milligrams. It's not really going to do that much more for you than 5 milligrams. So less is more in that way. And then reading Lee's question here. I have a paper actually I can send you guys that with the demented population, people with MCI or dementia. There's a recent group of us that put together behavioral recommendations that help with a range of different things, from sleep to anxiety. And I think, we want to make sure the caregivers get sleep. And so we really do focus on the environmental things. When are they exposed to light? How much, when do they have activity levels, regulating when they get into bed, when they get out of bed. There are patients that do benefit from medication. If their dysregulation becomes so extreme, then I think that's a good time for it. But definitely minimizing light in the evenings, maximizing it in the mornings, really trying to do some of those environmental things that help people identify that it's time to sleep are the first things I try. But yeah, any other questions? I get so excited I start talking about other things that you didn't even ask.
Well, thank you. I know you have to go.
And I'm so sorry about that.
Big round of applause. Thank you so much.
Yeah.
Sorry we couldn't do it in person, but
No.
really a great turnout, great questions, wonderful presentation. And thank you, Erin.
Yeah, absolutely. Thank you all. I will come back sometime. Maybe we can try this again in person. So
All right.
anyway.
Awesome. Thank you. Okay. Bye.
Bye.